Hi, Dr. Goldberg here, continuing our infectious disease and internal medicine lecture series. Today we're talking about acute pericarditis, inflammation of the pericardium, the sac around the heart. We've got a 32-year-old electrician who's been sick with a flu bug since working in the United Arab Emirates on a special government job. Gets sick, notices anterior chest pain with breathing, some shortness of breath, comes back to the U.S. On exam, has a pericardial friction rub on his cardiac exam as he's sitting forward. And of course, we suspect acute pericarditis. We do a EKG that shows global STT wave elevation on all of his leads. Echocardiogram shows thickening of the pericardium and some effusion. Of course, his chest x-ray shows a water bottle heart, which of course can be just very helpful in helping make the diagnosis in the emergency room. So often our patients with pericarditis present with chest pain. It's atypical, worse with deep breathing or cough and fever. The pericardial rub is heard best when the patient is sitting forward. And of course, we watch for complications of cardiac tamponade or constrictive pericarditis. The causes of pericarditis are generally going to be neoplastic, spread from lung cancer or breast cancer about 35% of the time. Certainly autoimmune disease like lupus can be associated about 25% of the time. When we get to infectious etiologies, most of it's viral, such as Coxsackie A, B, and the other enteroviruses in the summertime. But influenza, varicella, and the herpes viruses are also associated with pericarditis, so you got to keep an eye out for those. Bacterial pericarditis occurs in about 6% of patients. We'll see strep do it, staph do it, especially through hematogenous spread. But contiguous pericarditis from pneumococcal disease, H. flu, MCAT are all possible. The nephrologist is versed in uremic pericarditis, and the cardiologist, of course, is versed in Dressler syndrome, which is seen in patients with transmural myocardial infarctions. Remember TB if you're in a developing country, and idiopathic pericarditis is seen in about 4% of patients. Treatment is NSAIDs for 3 months, but if we don't see good control, we may add colchicine or use prednisone in refractory cases. But pericardiocentesis is helpful if there's an effusion, sometimes a pericardial window, and actually sometimes a pericardiectomy is required if they've got loculated fluid. So hopefully this is just giving you some good bullet points on pericarditis. Dr. Goldberg signing off.